Ladies and gentlemen, best greetings from Regensburg. We would like to present a case, 55-year-old male with acute aortic dissection 2014 in Greece, true lumen collapse, malperfusion of the right renal artery. He has had a femoral bypass due to ischemia of the right leg. Was 2 months at the ICU, critical illness, polyneuropathy, paralysis of the right foot due to prolonged ischemia. Now, dissection beginning at the left subclavian artery, ongoing annulus progression to 33 millimeter, and the true lumen, as you see it here, is getting narrow and ends at the level of the right kidney, which is actually atrophic. When we follow this CTA, you will see at the bottom the femoral bypass due to the occlusion of the right iliac. So this is the CT before our procedure. We planned a CMD branch for the celiac branch, celiac trunk, left kidney, and mesenteric inferior artery. The first procedure was a crossover bypass. The second connected to the TAAA, and then four branches CMD. We occluded the left subclavian artery with a 14 millimeter implanter. Now you see the first thoracic graft, tapered 38, 34. We, in this case, decided to get some ballooning at the proximal, and the second stent with an overlap of 3 stents going to 2 centimeters proximal to the celiac trunk. And as you see, it was a dissection scene of the inferior mesenteric artery. Now the CMD branch device deployed into the second thoracic stent. We look for the correct positioning and then deploy the stent graft completely. The iliac was only open on the left side, so we decided to use a tube graft, 22 times 117 millimeters from the branch device to the common iliac on the left side. As you see, the membrane stenosed the branch device. The first ballooning was unsuccessful. The balloon ruptured. The second balloon made his job, and we could have opened the graft completely. This is our implanter into left subclavian artery in order to avoid retrograde perfusion from the left subclavian artery into the dissection. So this is the CTA after the first operation. You see thrombosed thoracic part and still perfused some lumbars and lower intercostals. This is the CT reconstruction with this features. Second procedure in October, the covered stent grafts into the SMA, left renal artery, and celiac trunk. First, the catheter and wire into the left renal branch, left renal artery, exchange of the wire for the rosin wire, and we had to use here 2 big grafts because it was a longer distance. The maximal length of the bigger is 57 millimeter. So the first into the branch and second bigger one. The first was 9 millimeter, second 10 millimeter, big graft plus, and the control DSA. The second was the inferior mesenteric artery. This was a quite strong inferior mesenteric artery, and as I told you, this patient has had already some intestinal resection and dissected superior mesenteric artery. So we used here again 6 mm branch and big draft plus for the inferior mesenteric artery. The next one was the mesenteric, the dissected superior mesenteric artery. You still see a dissection here. We've got to the true lumen and exchange of the wires for the, in this case, Rosen wire. And first we implanted 210 × 37 big grafts plus, but at the end, we were not very happy about the sealing, so we used the third one and had additional ballooning. This is the control DSA. You see that dissection is a little bit better in this angiographic control. This is the patient well walking after the first two procedures. The third one was just occluding the celiac trunk using maps and intravascular pressure measurement. You see the catheter into the branch of the celiac trunk, wire into the celiac trunk. You see the pressure line before ballooning, now occluding the celiac trunk and branch, and you see the reduction of the pressure in the aneurysm sac. So we were sure we can exclude the aneurysm, and on the other side, maps were uneventful. So we are quite happy that the patient is not going to get paraplegia. Extension to the celiac with another 2 big grafts plus. This is the control with the proximal TAAA and the branching of the supraortic vessels. This is the branched part and the control CTA with a complete exclusion of the thoraco-abdominal aneurysm. So what we do for BEVARs in thoraco-abdominal aneurysm, prevent spinal drainage. We try to prevent flow to the left subclavian artery, stage approach with temporary aneurysm sac perfusion, intraoperative maps which define completion interval, and the completion either in local anesthesia or under maps. Thank you very much.